Good afternoon. I'm Dr. Shivaji. I'm pediatric cardiac anesthesiologist and intensivist at Fortis Hospital, Mulund. I'm going to speak about post-operative management of pediatric heart transplant recipients. So we had this patient, 8-year, 19 kg boy, known case of Wolff's anomaly with parchment paper, thin kind of right ventricle. There was non-coaptation of tricuspid leaflet, severe TR. His RA, RV were dilated. IVC was dilated. He had a swollen face and limbs. In addition to this, he had a significant LV dysfunction. So we had a clinical meet and we decided to put him on the transplant list as transplant was the best option for him rather than Fontan. So he was waiting for the heart transplant. Frequently, he used to get admitted for the heart failure treatment. And one fine day, we got a heart for him. Where we when we going for the when we going for the retrieval, we got a news that donor is arrested. So as we were near to the retrieval center, we went there. By the time that time they had revived the recipient, but there was significant LV dysfunction, and the donor was on high dose of inotropic supports. So as the donor was young, so we decided to take the heart, and the transplantation was done within 4 hours. And when we came off bypass, his CP was in single digit, LV was contacting well, RV was contacting well, everything was looking very well. While surgeons were doing hemostasis, protamine was given, surgeons were doing hemostasis. And then CVP started rising, there was hypotension. And when we did echo, this was his function. His RV were dilated, LV was dilated. So first thing that came into my mind was what is this? So is this a rejection? But his PRA class 1 and class 2 were negative. We do donor specific antibodies, that is a prospective cross match. Class 1, class 2 antibodies, donor specific antibodies were negative. So if this is not a rejection, so what is it? So we call it the primary graft dysfunction. What I mean to say is that it is a ventricular dysfunction in the immediate post-operative period in absence of graft rejection. Here what happens, the transplanted heart fails to meet the circulatory requirement of the recipient in immediate post-op period. Either it can be because of the LV dysfunction, RV dysfunction, or it can be because of both. And it manifests as a low cardiac output and hypotension in presence of adequate filling pressures. So how do we manage this? In this kind of situation, we use inotropes like adrenaline, noradrenaline. We can use inodilators like dobutamine, milrinone, levosimendan. If there is a sinus rhythm is not there, you can do AV sequential pacing. In bigger side of recipient, you can use IBP. Or if all these things are not working, you can put the patient on ECMO. So that's what we decided, to put the patient on ECMO. So this patient was put on ECMO. After putting on ECMO, RV were relaxed. His mean arterial pressure improved. He started passing urine. There was lactate started coming down, but there was severe LV dysfunction. On first post-op day, this was his LV function. LV was barely moving. There was just flicker of contraction. On post-op day 2, there was slight improvement in LV function, but we thought still he needs some support. On post-op day 3, there was a marked significant improvement in LV function, but we still waited for one more day. On fourth post-op day, this was his LV function. So we thought this is the best time to wean him from ECMO. So he was weaned from the ECMO, and after weaning from ECMO, this was his heart function, LV function. So in primary graft dysfunction can manage with the help of the ECMO, and we just have to be patient. These patients eventually come out of the ECMO. So this primary graft dysfunction is the most common cause of 30-day mortality after heart transplantation. But can we predict this primary graft dysfunction? So there are two main factors that are consistently associated with primary graft dysfunction. One is a prolonged ischemia time. Another is a preoperative mechanical circulatory support. In this, and in addition to this, there are other factors like advanced donor age, oversized donor, and especially when the left ventricular wall thickness is more than 14 millimeter, congenital heart diseases in the donor, coronary arteries in the donor, and preoperative use of high inotropic supports in the donor. This was on one of our recipients, 16 years, 40 kg boy. It's a known case of dilated cardiomyopathy. he was admitted in the another hospital, and he was arrested there twice. They told us he every evening he used to get arrest. So we got in admitted in our hospital, and in our hospital, so he arrested twice. So we thought it's better to put him on LVAD. So we had put him on LVAD. One cannula is in the LV, another in the aorta, and we could extubate him. And he was doing well, waiting for the heart transplant. But one fine evening, he had a significant RV dysfunction, so we had to go put him on, convert the LVAD into the ECMO. So he was put on the ECMO and waiting for the heart transplantation. As he was waiting for the heart transplantation almost for 15 to 20 days, we accepted a marginal donor for him. And after heart transplantation, 6 to 7 hours, he was doing well. After 8 hours, he started throwing this atrial arrhythmias. CVP started rising. There was hypotension. And we had a TE probe. We inserted a TE probe. His RA was dilated, RV was dilated. There was significant TR. We we did the transgastric imaging. In transgastric imaging, his LV function was also down. The striking feature here is the location of the septum. There was flattening of interventricular septum at the end of systole. So this is the most common problem that we encounter after heart transplantation. That is acute RV dysfunction. It's common, especially in the patient with pre-existing pulmonary hypertension and high fever. What happens here is there is significant dilatation of right ventricle, dilatation of trachea spinalus, and it leads to the severe TR. This acute RV dysfunction manifests as a rise in CVP, especially more than 20 mmHg, high PA pressure, and hypotension and the low cardiac output. So how do you manage this kind of situation? And in this kind of situation, the management is mainly ventilatory. We avoid hypoxia, hypercarbia, acidosis, avoid atopip. If there is no AV synchrony, we can do AV sequential pacing. If the donor is still unstable, we can use inodilators, optimize the preload. We can use dobutamine, Milunor, or levosimendan. In addition to this, if there is still RV dysfunction, we can use pulmonary vasodilators like sildenafil. We can use mechanical circulatory support in the form of RVAD or ECMO. So we decided to put this patient on RVAD. So there is one cannula into the, you can see the right ventricle is not contracting well. One cannula is into the RA, another cannula into the pulmonary artery. So we support him as soon as we put this patient on the RVAD. This is his transesophageal echo. You can see the one cannula into the RA. As soon as you put the patient on RVAD, his RA become relaxed, atrial arrhythmias disappeared. Hemodynamically, he became stable. Just within a period of 10 minutes, he became hemodynamically stable. Started like his lactate also started coming down. So this is how we can manage the RV dysfunction. This is one of our recipients. 4.5 years, 10 kg girl. She was known case of dilated cardiomyopathy. She was listed for the heart transplantation. And it is for pediatric patient, it's very difficult to get the donors. So we got a heart for her. Her donors weight was 37 kilos. So almost 3.7 times of oversizing was done. And we know that oversized donor is one of the risk factor for the primary graft dysfunction. So she had a primary graft dysfunction after transplantation, and she was not maintaining BP. So we had put her on ECMO, and she was supported on ECMO for almost 4 days. So initially there was hypotension, not maintaining cardiac output. Now when we weaned her from the ECMO, she in fact had a hypertension. So her BP was in 160s and 170s. This is just comparison of her pre-transplant and post-transplant X-ray. We can see here the post-transplant X-ray in heart is even bigger than pre-operative X-ray. So this is one of the unique problem that we encountered in pediatric heart transplant recipient. What happens is the large number of recipients and less number of donors. So most of the pediatric heart transplant recipients, they end up receiving an adult heart. So adult heart is used to pump large amount of cardiac output, and it manifests as systemic hypertension, cerebral hyperperfusion, and convulsions. So and we treat them with antihypertensive agents. The choice of antihypertensive agents is a calcium channel blocker, ACE inhibitors, and sometimes beta blockers. These patients actually, they don't need anticonvulsive therapy. This is one of our recipients, 13 kilo. and donor is 19 kilos. So in this kind of in this patient, we have to in fact undersize the heart. Almost 70% undersizing was done. And in this patient, there are, though the LV function, RV function, everything was normal, there was a significant amount of pleural effusion around the heart. Though as the patient was hemodynamically stable, we did not do anything. Patient was managed conservatively on diuretics, and after the period of 4 months, this pericardial effusion disappeared. Arrhythmias, transplant heart is a denervated heart, so normal heart rate is little on higher side because of the loss of vagal tone. Sinus node dysfunction is common, especially when initial days when the anastomosis or bilateral anastomosis. But nowadays, most of the centers are doing bicaval anastomosis, so we don't see much of sinus node dysfunction. Complete heart block and incomplete heart blocks, incomplete RVB are common, especially if the ischemic time is long, there is organ protection is not good, or if there is a surgical trauma. In this kind of scenario, we manage this patient on with isoprene and AV sequential pacing. Hardly 5% of patient they need a permanent pacemaker for the complete RVBB. Sometimes this patient can have atrial arrhythmias or ventricular arrhythmias, and this can be managed with the conventional antiarrhythmic drugs like amiodarone, beta blocker, and lignocaine. Immunosuppression. This is one of the unique thing that is happening in this patient. So first heart transplant was done by Dr. Christian Bernard in the 1967. So now this is 2022. So almost 5 decades have passed. In these 5 decades, there's a lot of newer immunosuppressive agent, newer immunosuppressive strategies are in clinical practice. So what has improved the outcome and survival in the heart transplant recipient is this. There is immunosuppression. So these immunosuppression strategies mainly depend on the preoperative, that is a PRA and SAB. So PRA is nothing but the preformed anti-HLA antibody in recipient serum against possible donor HLA antigen. So if the PRA level is negative, that is, if the PRA level is less than 4, we consider as a negative. And in this kind of patients, this is the immunosuppressive strategy we use. We use induction therapy. For induction, we use 2 main drugs. That is, one is basiliximab and second is methylprednisolone. So patients in basiliximab is interleukin-2 receptor antagonist. With patients less than 30 kilo, we use 10 milligram, and more than 30 kilo, we use 20 milligram of basiliximab. Methylprednisolone we use in the dose of 10 milligram per kg, 2 doses. First dose at the induction of anesthesia, and second dose just prior to the release of cross clamp. Maintenance therapy is a tacrolimus-based maintenance therapy. We use tacrolimus, mycophenolate, and steroid. So tacrolimus in initial period, as the chances of rejection is high, we maintain a little higher TAC level. In first 3 months, there's 10 to 12, 3 to 6 months, 8 to 10, and more than 6 months, 6 to 8. This is the TAC level we maintain, tough TAC level we maintain. Mycophenolate, we started the dose of 40 milligram per kg per day in 2 divided doses. And the steroid, we taper by 50% every day. So by the end of 1 week, patient is on oral steroid at the dose of 0.1 milligram per kg per day. So this is the standard immunosuppressive strategy we use when the PRA is negative. So what if your PRA is positive? That means PRA is more than 4%. In this kind of scenario, we have to quantify the anti-HLA antibody, not just quantify, but we have to identify this anti-HLA antibody. So how can we quantify? For the quantification and identification, we have 2 tests. One is a CPRA, it gives us quantitative value of the pan-reactive antibody. Another is a single antigen bid. By using the single antigen bid, we can just quantify, we can identify this anti-HLA antibody and quantify with the help of MFI. There is a mean fluorescent intensity. So most of the centers, as per the ISHLT data, most of the center consider if the MFI is more than 5,000, it is significant and it needs to be addressed. So in this kind of, but in our setup, we consider a MFI of more than 2,000 is significant, and we manage this patient differently. So how do we manage if the PRA is positive and less than 50%? So in this kind of patient, we do virtual cross match. For virtual cross match, we need SAB of the recipient and donor HLA profile. So it is a donor HLA profile is we can get even prior to the transplantation, and virtual cross match we can do before the even accepting heart. And for physical cross match, we need recipient serum and donor's lymphocyte. So we do virtual cross match as well as physical cross match. If the virtual cross match is negative, we don't wait for the physical cross match, we go ahead with the transplantation. But what if your PRA level is more than 50%? When the PRA level is more than 50%, this patient need desensitization therapy to increase the donor pool and mitigate the post-operative complications. So in these patients, virtual cross match and physical cross match is mandatory. If it is if anything is there is mismatch, heart should not be accepted. So how do we do desensitization therapy? The goal of desensitization therapy is to achieve negative prospective cross match. So we do desensitization with the help of rituximab. We use plasmapheresis and IVIG. And especially in this kind of patient, the induction agent is anti-thymocyte globulin. Rejection, as per the ISHLT data, the incidence of rejection is around 30% during the first year of heart transplantation. So rejection can be hyperacute rejection, acute cellular rejection, or antibody mediated rejection. Hyperacute rejection occurs within minutes to hours of the heart transplantation and is mainly due to preformed anti-HLA antibodies and is uniformly fatal. So how do we how can we avoid this hyperacute rejection? We can avoid by using by PRA screening and virtual cross match, by doing the virtual cross match of the recipient and donor. Acute cellular rejection is the most common form of rejection. Almost 50% of the recipient experience some kind of acute cellular rejection, especially in the first year after heart transplant. So there is a different grading of acute cellular rejection. I'm not going into the detail of that. But what I want to say is, whenever there is a evidence of myocytic injury on biopsy, this needs to be treated. How do we treat this? The main set of treatment is a steroid here. So we treat with the steroid and optimization of immunosuppressive therapy. And if there is a graft dysfunction, then we have to use inotropes and consider anti-thymocyte globulin. Antibody mediated rejection is common in first week to months of the heart transplantation and is usually associated with graft injury. So we do antibody mediated, how do we diagnose this? When there is a presence of immunoglobulins IgG, IgM, and complement 3D, 4D, and complement 1Q, and CD68. That is, there is a marker for the macrophages. When these are present, it indicates there is an antibody-mediated rejection. And as per the ISHLT data, at least 5 EMB endomyocardial biopsy should be done for the diagnosis of AMR. See, this is the different grading of the AMR. When there is a present, depending on histopathological and immunopathological features, when these both features are absent, is a grade 1, both are present, it is a grade 2, and if either is present, it is a grade 1. So whenever the any grade of AMR in presence of presence of graft dysfunction, it needs to be addressed. How do we address it? With the either with the removal of antibody with the help of plasmapheresis or immunopheresis or plasma exchange, by the decreasing the production of antibody with the help of rituximab or cyclophosphamide, and T cell depletion with the help of steroids and ATG. Infection and prophylaxis, as these patients are on immunosuppressive medication and catch infection very early. So we nurse this patient in separate isolation cubicle with 2 well-trained nurses. As per our protocol, we get donor sample for the blood culture from the donor. And our antibiotic policy is to use piptaz and targocid as this is our initial antibiotic choice. We send blood culture every alternate day and change antibiotic policy accordingly. So this graph shows that in first month after heart transplantation, the chances of bacterial infection and wound infections are more. So and in second, third, and fourth month of the heart transplantation, chances of viral and protozoal infections are more common. So as per the ISHLT recommendation, we use antiviral prophylaxis against CMV and HSV in the form of valganciclovir. We start valganciclovir on the third post-op day, and we continue it for almost 3 months. In patient when the recipient is CMV negative and donor is CMV positive, in this kind of patient, we continue valgan prophylaxis almost for 6 months. As per the ISHLT data, ISHLT recommendation, we use antiprotozoal prophylaxis in the form of Septran, single strength Septran, and we continue it for almost 1 year. These are a few our heart transplant recipients. Thank you.